So I'm happy to welcome back to the stage Dr. Paul Abramson. He is a doctor with an active private practice in San Francisco, where he spoke to us about that practice yesterday, where his patients were using self-tracking for health and greater awareness for many years. His practice has always been really innovative in bringing in new tech and ideas and building an integrated practice around patient care, often ideas that are really unconventional or older ideas. And he's actually going to talk to us today about ketamine being rediscovered as a medicine to augment therapies, especially for treatment-resistant disorders. Um, he'll discuss the early results from his team's use of ketamine-assisted psychotherapy for severe depression, OCD, and PTSD, and ketamine-assisted treatment of chronic pain. And he'll also give us a little insight into the reemergence of psychedelics in American medical practice as it's being researched by educational institutions and the military. Anyway, I'd really like you guys to welcome to the stage, back to the stage, Dr. Paul Abramson.
Thanks, Glenn. Hi, I'm Paul Abramson. I'm a medical doctor and a former engineer in San Francisco, and I'm going to expand on a topic that I mentioned yesterday when I was talking about self-tracking, which is the concept of patients who get into really stuck places where even our crazy and complex techniques can't get them out of that stuck place. It could be a situation, a point of view, a diagnosis, and that's going to segue into ketamine, which is a dissociative and psychedelic drug that's actually been used in American medical practice for decades as an anesthetic agent, mostly in ER and ICU settings. But it's now getting another look from the scientific community and the medical community for use in really treatment-resistant psychiatric conditions like depression and OCD, and also in the chronic pain world, mostly anesthesiologists. So we've been exploring this, newly empowered by all this new research and clinical findings, and it finally got to the point where we thought we could introduce it into a private medical practice and see how it works with actual people outside of a study. This also leads into a broader look at the use of consciousness-expanding drugs like psychedelics in medical practice. And why would you want to do that? Well, sometimes when people are stuck, you need to kind of loosen the screws or lubricate the brain machinery in a way that maybe people could move in different ways, both psychologically and physically. So I'm going to give you some context about the environment in our practice that I've created where we're doing ketamine-assisted treatments. Also talk about ketamine and actually give you a few case studies of people we've actually treated in the 6 months that we've been doing this. So then I'm going to also put it in the general context of how we work with patients and our concept of N-of-1 studies and really empowering people to figure out for themselves what is going to work for them. So my grandfather and great-grandfather were both physicians and surgeons in the early and mid-1900s. They exemplified this physician who didn't have a lot of technological tools. They had surgery and they had limited amounts of knowledge about microbiology. And late in my grandfather's career, there were antibiotics. But really, they were often dealing with people who were in pretty untenable conditions that were going to result in a loss of function or a loss of life, and really sitting with them and providing psychological and spiritual support as part of their job. It was just really expected. And I think here's some illustrations up on the slide of the use of ether in a surgical environment. And they used to do surgery in front of an audience. And ether was actually pretty barbaric by today's anesthesia standards, but it was a really great advance over bourbon and a strap of leather to bite on. So it turns out that even though they didn't have a lot of tools, they had very, very, very satisfying careers as healers and hands-on healers. So that segues into our current medical practice in San Francisco. I actually worked in the ER and the ICU for years and finally sort of got fed up with the assembly line of medical care and started my own private practice because I saw from my engineering background and my other adventures that there was probably a better way to do medical practice. So I started solo, just one doctor in a medical practice, and figured out that this is way too complex to do alone. So I've now gotten a team of different kinds of practitioners who work together to provide general medical care. And now that we have psychologists and therapists and other kinds of practitioners, we can now start to take on some of the less tangible parts of medical practice around psychology and behavior. We have an addiction medicine for professionals who are addicted to things, component of other practice. We've returned to something I actually learned in residency, but I now appreciate a lot better, called behavioral medicine. It sort of takes psychiatry out of the picture, and it just looks as, I seem to have lost my slides, but it takes psychiatry out of the picture, and it just looks at people as whole entities, whether it's medical or psychiatric or spiritual, and tries to put this context of how to supervise them in a medical context. And, okay, here we are. And treat them as whole people. So now we have a doctor, a physician assistant, a nurse practitioner, a psychologist, 2 master's level therapists, a dietitian, and a Chinese medicine doctor. And by the way, we are recruiting and looking for another medical doctor to join us. So if you know anyone who might want to do that, please send them my way. So now instead of, actually in Northern California in emergency medicine, they actually evaluate emergency medicine physicians on how fast they actually call it moving the meat in an ER, how fast you can move people through. And instead of doing that, we're now taking each person and following them and applying everything we can to individualize and optimize the treatment of each individual person. So the old system I used to work in involved a physician and a patient, but the patient also had all these other people they were working with, none of whom communicated with each other. And so this is something that's really broken about our current medical system. And the role of the primary doctor has really become to refer people to a disconnected array of specialists. And in practice, that could work if everyone could communicate, but I found even in academic centers where everybody works for the same organization, it's really hard for everyone to communicate, and the culture of medicine doesn't really encourage that. So the model we've constructed really puts the patient and the physician and the therapist and their team in our practice at the center inside this wall where everybody communicates, and then we help them to interface with the outside world. And this relates to the ketamine therapy because this little circle around our team provides a kind of containment and a sense that we're going to find out what's going on and we're going to be able to help adjust things if they're not working out. And that has really empowered us to go out a little bit on the edge of some ways of working with people that involve a little bit more risk but have potentially a lot more return because we have a container built around it. So I'd like to define stuckness. It's a word. It actually is a word. And Webster's, I think, says it's to be unable to move or be moved or to accept or to tolerate an unpleasant situation. And I think in any way, anyone who works with people finds people who are stuck. And maybe, probably everybody experiences being stuck at one time or another. And it's one of these frustrating things where the harder you try, sometimes the less successful you get at getting people unstuck. So in medical care, what gets stuck? The examples I'm going to choose are from the literature that now exists around ketamine. There are many, many, many additional things, but depression, trauma and stress and post-traumatic stress disorder, obsessive compulsive disorder involving obsessive thinking and compulsive actions, and also the response to chronic pain, which is often a long-term situation that sets up a dynamic with the brain and the body and the psyche that can get really stuck. So our approach before ketamine entered the picture was just really a thorough medical approach where we have rapport with the patient, we have a container, we have a team, we're pretty creative, we do these N-of-1 experiments with people. And that's fine, except often we encounter people who come to us having already done that for 10 years, and now they've reached a crisis, or a crisis comes up in their life around whatever they're stuck with, and there really isn't time to iterate on N-of-1 experiments for months or years. Sometimes we need answers now, or it's a patient who's suddenly and severely suicidal. So we were really looking for new tools and creative new options to help people who got stuck in a way that needed action right away. So I'd like to take a little detour. I have a long-standing academic interest in psychedelic-assisted therapies. They were mostly studied before I was born in the 50s and 60s. And that research was incredibly promising, and there were thousands and thousands and thousands of journal articles published on psychedelic-assisted therapy and all sorts of things until the mid-60s when the DEA rescheduled all of the psychedelics to Schedule 1, meaning no medical use. And then I was born, and later I thought maybe I was born a couple decades too late. But in the last, I would say, 5 to 8 years, psychedelics have started to come back into research. And now all of the major medical centers and academic centers in the US and in Britain and Israel and other countries are now studying in an FDA-approved fashion psilocybin, LSD, and other psychedelics for use in medical and psychiatric conditions. So that's pretty exciting, and it's really hit the press with Michael Pollan put out this article, The Trip Treatment, in the New Yorker last year, and then it started to really snowball. So now it's pretty much every week there's some new article on psychedelics in medicine. And because the FDA and DEA-sponsored research has so many strings attached, the catch of all this is it's going to be 5 to 10 years before there's anything that's available outside of a study. And the studies are pretty limited because it's incredibly expensive to do FDA-sponsored research. So nonetheless, I'd like to just plug someone a group that I'm not affiliated with, but at NYU, they're doing a study of people, mostly psychedelically naive people with end-stage cancer who are suffering from severe anxiety. And they were able to recruit lots of people for this, amazingly, where they gave them high-dose psilocybin in a setting of ongoing psychotherapy and support. And the results are truly phenomenal. They have a documentary that it might be out already or it's going to come out soon that has interviews of these patients, and I recommend everybody find that and look at it when it comes out, because these are middle-aged people, young people, old people who were crippled with anxiety, and after one session of psilocybin had complete revolutions in their life and were able to really feel both relief of suffering and a new excitement about making the most of every moment they had. So it's a really inspiring bit of research. And that's just the tip of the iceberg. There's so much stuff going on, which is very exciting, but it's really not coming to any local treatment paradigm anytime soon because of the regulatory stuff. So I'd like to switch to ketamine. As it turns out, all consciousness-expanding drugs in the United States are currently Schedule 1 and illegal for use outside of a study, except for one, and that's ketamine. It's actually Schedule 3, which is the same as like Tylenol with codeine. So it's actually pretty lightly scheduled in the US. It's FDA approved for use in anesthesia and conscious sedation where in the ER or ICU. And it's actually on the World Health Organization's essential drug list for developing countries because unlike the other anesthetic agents, it doesn't make you stop breathing, and it doesn't drop your blood pressure, and it doesn't have a lot of the risks that require ICU and anesthesia monitoring. So they actually use it in Africa and other developing countries to do anesthesia on humans. It's also the most widely used anesthetic used in veterinary practice, ketamine or an analog of ketamine. So I sometimes wonder all the thousands and thousands, I have a lot of veterinarian friends, all the thousands of animals that companion animals they've anesthetized in the last year, and basically, what is the effect on these cats and dogs of being given moderate to high-dose ketamine? And actually, we'll touch on this later, but this is also the source of a lot of recreational use of ketamine is from a veterinary source, repurposed. So in human medicine, in my time in the ER, I gave dozens of children ketamine when sewing up a laceration on the face. If you have a young kid who's really feisty, it's a great drug for that. It's very, very safe. However, it has an interesting side effect in that it makes the child leave their body and their eyes become vacant. And often that causes a side effect in the mother or father who's like, where's my baby? And it's really dramatic. And if you don't counsel them ahead of time, they think their child is never coming back, but they always do come back. In humans, it's not used nearly as much because of this effect and because unlike children, when adults come back, they frequently have what they call an emergence reaction, which is essentially a re-entering of the body and a conscious awareness of having been in this dissociated psychedelic state. And in a medical setting with lots of bright lights and no counseling, this is pretty frightening to adults. So when we use it with adults, the standard of practice is to also give them Valium or Versed or some sedative so that they don't remember the experience. But it turns out that this transpersonal out-of-body experience that's been given to people in the US, and I bet in this room there's probably at least a couple of people who had ketamine as a child in the ER and probably don't remember it. But it's, some of these side effects are actually potentially really therapeutic effects that have not been leveraged at all until recently. So this is a cartography of psychoactive drugs. And it's not really important to look at the details, but ketamine falls somewhere between the psychedelics and the hallucinogens and the depressants and the dissociatives. And probably the most closest agent in terms of the dissociative effects is nitrous oxide. But ketamine does a lot more than nitrous oxide. So this is also not that important in its detail, but this is the sort of current state of the art on what ketamine does inside nerve cells in the brain. And it affects many, many, many different processes. It seems to increase glutamate, which is one of the neurotransmitters. It also increases a chemical called brain-derived neurotrophic factor. And it also hits opiate receptors, so it reduces pain while inducing a dissociative state. But the science is really new and being worked out, and now that it's being studied for depression, pharmaceutical industry has a lot more interest in this old drug. So we'll know more soon. But and if I'm going to talk about neurobiology, I have to show a functional MRI. This is just the time course of ketamine's effects on different brain centers, starting in that little spot in the front of the brain, which is the oculofrontal cortex. So it induces visual changes very early in the course of its effects. So the one thing that's kind of interesting is this buzzword called neuroplasticity, which is either making new synaptic connections or changing synaptic connections in the brain that might lead you to be able to rewire yourself and potentially change things that are stuck. So at least if you're a rat in this study, ketamine seems to induce very rapid neuroplasticity in areas of the brain involved with addiction. And there's a lot of work being done on this, but this is in the last year. So this is another complicated diagram, which is actually the subjective experience of human studies, or of human subjects, on either psilocybin, the active ingredient in magic mushrooms, or ketamine. And if you're looking at perceptual changes, insightfulness, mystical experience, cognitive changes, ketamine has a lot of similarities to psilocybin. And psilocybin is being studied at Johns Hopkins, NYU, and many other places. It's very exciting, but it's not here yet, whereas ketamine is here today. And the interesting other thing is this is not apples and oranges. This is a very high dose of psilocybin, equivalent to 4 grams of psilocybe cubensis, and only a 0.5 milligram per kilogram of IV ketamine, which is a very low dose. So ketamine is probably even more like psilocybin than we would otherwise know. So, and this is just another neuroanatomy comparison showing that even though they act on different parts of the brain, the downstream effects of both psilocybin and ketamine are very similar. They both induce glutamate release and BDNF, brain-derived neurotrophic factor release. So, and they also light up similar parts of the brain on a functional MRI. So now I'd like to switch gears again and get into the dark side of ketamine. I bet there are people who have tried ketamine recreationally in the room or who know people who have. And even though ketamine has all this wonderful potential, kids at raves seem to love it. And it's really the only psychedelic, in my opinion, that has true addictive potential. So there's a lot of stigma around ketamine use in psychedelic research circles because a lot of these neuroscientists who have been experimenting on themselves with psychedelics have seen themselves or others taken down by ketamine. And so we take this incredibly seriously. And in the practice, we actually treat ketamine addiction in addition to using ketamine for therapeutic benefits. So we actually have firsthand knowledge of people who have gone down the rabbit hole with recreational ketamine. And we strongly advise people not to do this at home because when in a non-supervised recreational context, a certain fraction of people will really have bad outcomes. It can involve toxicity to the bladder, paranoia, psychosis, and other really things that sometimes don't reverse when you stop doing the ketamine. So luckily there's a substantial body of evidence now that medically supervised ketamine in selected patients who are doing this for therapeutic reasons does not seem to really induce addiction. So, and we've pretty much seen, we've been concerned about certain people where they have an addiction history and we're using it for other things, but we really haven't seen any problems, and that's borne out in a fair amount of literature. So just two examples from the popular culture. The first is John Lilly, and the second is Dr. House. These are two physicians who got into ketamine actually trying to fix themselves, and that's part of the fantasy world that ketamine recreationally can induce, is the sense that it will let you fix thorny parts of yourself, and then people get wrapped up in that and can't stop. So both of them, even though they felt like they were in control, in the end it looked pretty bad from the outside, and that's a common endpoint with ketamine addiction. So I'd like to talk about ketamine and treatment-resistant depression. That's the one that's gotten the most press in the scientific and popular literature. But first of all, I need to say ketamine is FDA approved for anesthesia. So how is it that physicians are now using it for depression? There's this thing called off-label use. Once a drug is scheduled somewhere 2 through 5, where it's legal to prescribe for anything, physicians are actually free to prescribe it, they call it off-label, for other uses. And that's actually widely done, probably, I don't know what the exact number is, but a pretty substantial fraction of all prescribing in the US is off-label, because once things get approved for one thing, there's no one's going to pay for a study to get it approved for other things. So, so on an ethical basis, though, because we're using it off-label, we really needed to wait for enough research and precedent to arrive before we felt comfortable in this private practice setting going and using it. So, but I also had administered it to dozens and dozens of patients in an emergency setting, so I had a pretty good feel for its pros and cons and risks and how to manage it. So, why would you want to use ketamine for depression? We have all these other drugs. Most of the other drugs take weeks. Like Prozac takes weeks to take effect. Ketamine seems to have an effect, and that's just one reference of a meta-analysis of studies. It has an effect within hours in 70–80% of people. With severe depression, it causes a rapid reversal of depression that lasts a week or two. So if you have someone in a really urgent situation, or if you have someone who's tried everything and isn't working and just needs some sort of ray of hope, you can get them pretty fast relief in a lot of cases. And that can really be changing. It can really inspire people to do other things that they've been stuck and not doing. Obsessive compulsive disorder is another very stuck condition. The mainstay of therapy right now is drugs like Prozac and cognitive behavioral therapy, but neither one of those works quickly. And it's really hard to get someone who's really, really, really obsessive to do things in a timely fashion. So OCD can be very, very, very disabling and tragic, and it also seems to have a very robust and quick response to ketamine. And post-traumatic stress disorder is near and dear to my heart because, as I've known for years, it's not just about physical trauma. The VA is now stuck with hundreds of thousands of veterans with PTSD from physical and emotional trauma, but it's a widely underdiagnosed thing that psychological and emotional and other kinds of stimuli can induce PTSD, and I think it has a lot of downstream effects in our society. So MDMA is currently being studied. That's ecstasy, the scientific name of ecstasy, to treat PTSD, but that's also 5–6 years away from rescheduling because it's stuck in, I think they're about to start phase 3 trials. So, so the container is basically, we do we're still pretty conservative about how we use ketamine in our practice. We assess people medically and psychologically. We have them in the long-term therapy. And we add ketamine to that mix to try to get things to move faster. But we're not just sort of trying to use ketamine as a drug outside of a context. It also frequently requires monitoring, both heart rate and blood pressure and oxygen. And sometimes we have to actually give people medications to lower their blood pressure, treat nausea and vomiting. So it's a relatively high-touch kind of experience to put people through a ketamine session. It probably could be done simpler, but we're really trying to be as careful and responsible as we can right now. So obsessive-compulsive disorder. I'd like to talk about a case fairly recently in the last month in our practice. It was a 30-year-old tech worker, a woman who had a long history of severe obsessional thinking, procrastination, internet addiction, compulsive behaviors, social anxiety, was just really stuck, had been through lots of therapy, had tried different kinds of meds, actually came in just for a medical checkup because I'm this engineer doctor. And after we talked, it just really came out that her OCD was the major problem, actually. So I had our psychologist see her, and after a while, we all decided to add ketamine because the patient was like, "You're prescribing cognitive behavioral exercises. This is going to take 10 weeks. I can't even get out of bed to go to work. I'm checking the stove 40 times before I leave the house. It's just a real mess." So our hope was that ketamine would speed things up. And this is actually data from we're now collecting some validated research data on each patient, not so much as a population study, but just so we can track what's happening. And so this is a Yale-Brown OCD symptom questionnaire, and she was very, very severe before her first treatment, and after the first treatment, it was almost in full remission. And after the second treatment, it was even better. And I think the patient was ecstatic and effusive about how much things seemed different. But actually, the most actionable thing for me was my psychologist's face when she was talking about the sessions with the patient. She had just never seen anything like that before. Someone who was completely stuck and then became completely unstuck, had a bucket list, was planning an around-the-world trip. It was just a really dramatic and morale-boosting for everyone kind of experience. So, and the patient had many quotations. We do have them write some journaling before and after. And whereas before she was really stuck, now she was touching into her heart. Things were giving her peace. She was feeling lighter. She was letting go and making big changes. And she actually subsequently has made many, many big changes that she had been putting off for years. So case number 2 is sort of in the depression and chronic pain realm. This was a middle-aged woman who had 30 years of psychotherapy, 10 years of psychoanalysis for depression, had been through every drug, had had magnetic resonance, brain stimulation, had had a lot of different things done, and was really at the end of her rope with the depression, also had chronic pain. And so we started out actually with a chronic pain protocol, which is long IV infusions, and then moved to more of a depression protocol. And this was earlier in our use of ketamine, so we didn't have as much data collection going on. But what really happened was an almost immediate relief of depression. That came back. The depression came back after a few weeks, and we did repeated sessions, and each time it seemed to last longer and longer. So now she's pretty much done, she says. It's been a few months, and she's not really planning any more ketamine. She seems to feel better and has done all these other changes in her life. So she actually reported that for the first time in 10 years, she had 3 days of no pain. But the pain came back, unfortunately, but she said that just having had 3 days of no pain was so inspiring that she decided to go back to school and do something totally different with her life, because before that she was just completely hopeless. And she likened the effect to her experience 25 years before when she first tried Prozac, which had long since stopped working. So case number 3 is a case of depression and social anxiety, and this was actually maybe the most depressed patient that our psychologist and I had ever seen. So she had been through every class of antidepressant, mood stabilizer, antipsychotic medications, and had actually had 10 sessions of electroconvulsive therapy, which worked but caused such bad memory impairment that she couldn't work. So she stopped that. So I had been seeing her for a few years as a primary care medical patient, and she really didn't have much interest in changing anything until recently when she said, well, do you think I should do some more psychotherapy? And so I perked my ears up and said, well, why now? And it turned out she had really been going downhill and was starting to have work consequences and social consequences of her depression. So this was actually a pretty clear-cut case of treatment-resistant depression that fit almost the same population that all the studies had been done on. So after the workup and the psychological evaluation, we started her in therapy and added a session of ketamine. And the interesting thing here is that the data actually doesn't look that dramatic. Although the different depression scores did go down by a significant amount, the patient actually said she didn't feel any different. She didn't think it worked. But once again, it wasn't the subjective experience that was the most actionable thing. It was what the therapist noticed. All of a sudden, they were having discussions about what was going on under the surface. And she was interested in doing psychotherapy again for the first time in years. And she had all this new insight about what if there isn't a physical. She had been just doing drugs and going to different psychiatrists. What if it isn't a physical thing? What if this is more of an existential issue, and what does that mean for my approach? And so after we kind of reflected this back to her, she actually got much more hopeful. So sometimes it's not even the measurable things, it's the subjective feeling of what happens with people that is the most magical part of this. So what have we learned? So this is all very exciting, having these sort of quick responses to a drug. But that's actually not the thing we're most interested in. It wears off after a week or two. It's temporary. What we're really interested in is coming up with plans for people, finding out they can't execute on those plans, and using this as a way to get things unstuck so they can actually execute on the actual plan. And trying to use our human support team to facilitate that and make it safe. So really alleviating human suffering is the end here, not using a new drug in a fancy way. And ethically, we actually view all these tools, whether it's self-tracking gadgets or technology and apps or ketamine, as just tools to help empower people to achieve their goals. So to that end, we're just paying very careful attention with the language we use and how we present this. It's just a tool. It's not the end point. And I'm just going to end again with this cautionary note that ketamine is not a completely benign substance. It has addictive potential, and some very bright and forward-thinking and educated people have been taken down by ketamine. So there have been several documented deaths by drowning and people in their bathtub shooting ketamine. And it's also widely known that ketamine addicts routinely lie about their use and take extreme measures to avoid getting intervened on or having their supply cut off. So as with any really effective treatment, ketamine is both a powerful medicine, has a powerful potential to alleviate suffering, but it's also got a really spooky potential for harm and tragedy. So in our medical practice in San Francisco, we have this whole context where we can try to do this in an ethical fashion, and we're really exploring the ethics of using consciousness-expanding agents in a non-research setting with real people. And so this N of one paradigm, if it's done correctly, can be a really exciting way to work with people. I'd also like to mention that we are recruiting a physician. So if you know any physicians who would like to do interesting things in San Francisco, just have them get a hold of me. Thank you. So, happy to take questions if there's any.
So we definitely have time for questions.
Yeah.
And please come up to this to the open mic and Ask him.
First, a comment about
Sure.
the psilocybin research. There was a documentary published last year by a producer here in town called Robert Barnhart.
Uh-huh.
It's called The New Understanding of Psilocybin, The Science of Psilocybin.
Oh, yeah. There's been many
Yeah, so
awesome things, yeah.
that was, and it's available online if anyone wants to look at it. You can actually download it.
Sure.
I was interested in so you really put this within a whole setting of a psychological preparation.
Mm-hmm.
And how long does that take? Is this one dose of ketamine? How long does the experience of that ketamine last? Is it a half hour or 2 hours? Or what's sort of the mechanics of it? And finally, where do you think this is going in the future?
Well, that's everything. That's a very
Well, get started.
comprehensive question. So yeah, it actually varies for every patient. Most of the patients we've done this on so far are patients in our practice that we know pretty well already. Whether it's me seeing them medically for months or years, or some of them were already in psychotherapy in our practice and continued in therapy. We're now taking referrals from outside, and our basic model is to have at least a few sessions of psychotherapy before and after to kind of prep people and help them integrate the experience. The protocol we use for the dose and the duration of action depends on whether we do it intramuscular or IV, and whether it's a longer drip or a shorter injection or infusion. Intramuscular ketamine lasts about 40 minutes of the actual peak effects, and people are pretty much back to baseline by 2 hours most of the time. But you can run an IV drip of ketamine. Some of the chronic pain studies have done 72-hour continuous IV infusions, which is pretty grueling, actually. So we haven't done. I think that longest we've done is 6 hours for chronic pain. So where is this going in the future? Well, eventually there are going to be more agents available, and we're going to be able to figure out what's right for what condition and who, and have a more nuanced discussion of this. Really, I think this is just early days. Most of the psychiatric literature is using very, very low-dose ketamine, barely perceptual, maybe mild intoxication effects for depression, but it can be dosed in a variety of ranges, all the way up to anesthesia, where you have no memory and you're just out. So some of the dissociative and psychedelic effects that you get at higher doses may have benefits in addition to just the basic pharmacology of the low-dose ketamine. So we're interested in that as well, but we're not really sure yet of what's right for whom, and we're just being as...
I have another question. Do you use it at all for people who are in a depressive state or traumatic stress? Or, I mean, use it as just as an enhancer of awareness, and sort of like ayahuasca would be used, or things of that nature?
Well, we're in a medical context, and we're using it, and we're very mindful of the fact that we're not just in an unrestricted underground environment. We're in a medical context, so we're really trying to use it in a similar fashion to what the research has been done on so far. Right. And so, yeah, do you have a way to
I'd
frame
actually
that?
like to do a follow-up on that. Is like, what are are you seeing any other doctors pick up this kind of suite of techniques you're using? Are you hoping to see more of that?
There are a variety of people doing this around the country, mostly in psychiatry and anesthesia for the pain, and the psychiatry for depression. Most of the discussion has been pretty much either in popular press or some in the scientific literature, and then a lot of sort of very informal discussions. I think there's some movement afoot to make it more regimented or more regulated. Right now it's pretty much a free-for-all, and I think that's why we've chosen to do a more structured container instead of doing it kind of ad hoc. And I think there are many ways you can go with this. We're just choosing the way that we think is the safest and most effective, and that we understand the best to get going and help people, because there are people who need help right now and don't want to wait for everything to be sorted out. So I would say we're taking probably a more conservative approach than average, which has some higher cost because there's a lot more people involved than just having people into infusion clinic to get a dose of ketamine and sending them on their way, which may have some benefit, but I think it has more risks of people having a harder time integrating that
I think
experience.
the mindset before you take this is very important.
Oh yeah, I mean, setting and
That's everything.
the technique and the way it's framed and the safety and the container are incredibly important. I think that's not being addressed adequately in the scientific literature. I think the studies that are going on with psilocybin and LSD, the people doing those studies, I know most of them, and they're very mindful about this. But I think in sort of free-for-all private practice, I think there are a lot of people jumping into this who don't really know what they're playing with here.
And one more question,
Yeah.
medical reimbursement? Is this all
Um,
private pay?
well, it's a medical visit, and there's, the cost of the medication itself is minimal, but the psychologist sessions and the medical visit are potentially reimbursable by insurance. So it's not any different than any other medical care. The person who sits with them, if they're doing a long IV infusion, that may or may not be reimbursable. I mean, there are parts of this that involve long amounts of time that I think the insurance system probably don't understand. But the basic concept of a medical visit and procedures and psychotherapy is something that is fairly straightforward.
Super, nice job.
Thank you.
Hi, I kind of have two questions. They're not quite as lengthy, I don't think. The first one is, why is the ketamine more addictive than some of the other like psychedelic drugs? And the second question is, does the patient need to be off of like other like antidepressants or pain medications before they start the treatment? And are you willing to work with, like, I wouldn't have the ability to go to San Francisco. So would you be willing to work with an open-minded general practitioner in another area?
Why is it addictive? Actually, I don't think anybody knows. It's very different in feel from other psychedelics. Most of the classical psychedelics have a serotonin neurotransmitter mechanism in how they start affecting the brain, whereas ketamine works on this NMDA receptor and works more directly on glutamate. So it's got a very different, even though it has some of the same subjective arenas that it works in, the look and the feel of it is very, very different. And it also hits opiate receptors, whereas other psychedelics don't. So it's also more dissociative than any of the other psychedelics. It's more out of body. You go somewhere else. And that the stories that I've heard from people who get addicted to ketamine is that this other world that they go to becomes almost more real than this one. And that change in perspective doesn't really change when they stop doing ketamine. So they have to keep going back there. That's a common report.
Instead of being able to bring that reality into...
It's hard to integrate with repeated use outside of a therapeutic context. It can get really tricky because people's entire reality shifts in a way that they can't see.
Okay.
So that's pretty spooky in my estimation.
Yeah.
What was the last part of your question?
Would you be,
Oh,
well, I
oh
was
yeah,
also
working
wondering-
with other doctors.
Well, and does the person, especially if it works on like dopamine receptors and things like that, does
Oh,
the
it's
person
in
need
terms
to be
of
off
other
of other medications?
drugs.
Yeah.
There are not a lot of direct drug interactions. It may have effects on the short-term effects on the effectiveness or the levels of other psychiatric drugs and other medical drugs. So we just, every time we see someone, we assess what they're on, and we try to, as best we can, to determine whether there's going to be an interaction and whether we need to make any changes. But ketamine is relatively clean in terms of its interactions with other drugs. In terms of someone out of state and me giving advice to another doctor, I think that would be, I feel pretty confident in our container with our team and our protocols and everything being done. I'm a bit OCD myself, being done to a really meticulous level of attention to detail.
Yeah.
I feel pretty safe about how we're doing things. How to teach that, especially over the telephone to someone I don't know, I think that'd be very hard. We've seen a lot of things come up that really take some experience to help deal with, both in terms of emotional stuff that comes up and behavioral stuff that comes up, and even some medical things with extreme blood pressure elevations and vomiting and risk for aspiration and things. So it's not a, I would say it's not a simple, it's a complex in medical terms to do it right and to do it safely so that most of the time it's simple, but when it's not, it can require some readiness to jump into action over
I
the
can
course
see
of
that.
minutes.
How
So,
often
yeah.
would somebody from out of state, then if they were interested in seeing you or going through the program, would you recommend they come and see you then?
They should just give us a call,
Okay.
and we can talk to them and find out what's going on and figure out what makes sense. Because I think everybody's situation is different, and it just depends on how stable people are and what we think is going to be the most helpful way to go. But this is not just, it's available in other states and in other contexts.
Okay.
I mean, I've even heard that Kaiser in Northern California is doing ketamine for resistant depression. So it's
I'm going to ask another follow-up, which is
Yeah.
how much are you documenting your process?
Our process internally is exquisitely documented by my ace assistant, Stephanie, who has come up with protocols and checklists and how to set up the room and exactly how to administer the questionnaires. And we're gathering, as best we can, we're trying to find research instruments and questionnaires that we can do to track their symptoms. So our process is pretty well documented, and then as we change it, we're keeping track of what worked and what didn't.
I hope someday
So-
you publish some of that.
We would love to publish it, except it's also sort of like a don't do this at home at this moment, because there are a lot of, the art of this is in helping people through the experience and whatever comes up, which is unpredictable. So that is something that is more of an art than a protocol.
We're doing okay on time, but
Yeah.
Thank you.
Yep, thank you.
Hello.
Yep.
Hi. My question is, what types of PTSD have you treated with, what is it called, ketamine?
Ketamine, yeah.
And have you seen long-term transformation health-wise or mentally?
Right.
And the patients that you've treated? I have a couple more questions.
The studies are few right now and not long-term in the research literature. Our experience with ketamine, we only started doing this in September of last year with live patients. We've been thinking about it for a long time. So we don't have long-term follow-up, but we have a few cases of PTSD, some of them with more emotional trauma or physical trauma from childhood, one or two, depends on your diagnostic assessment, but one or two military PTSD kind of situations that were, but in reality, diagnosis is tricky, and a lot of people with PTSD also have other things going on. So I think the studies are able to just select only the people with very pure PTSD symptoms, whereas in our setting, people have more than one thing going on. So I would say our early subjective opinion is that yes, it's pretty awesome, but if people have other things going on, there are some other conditions that we won't use ketamine with. So we really are very picky about who we select right now.
So what have you found ketamine to be detrimental for?
There's a class of conditions called personality disorders, and sometimes ketamine induces states of mind that are pretty alternative, and sometimes in combination with personality disorders, it can be pretty upsetting to people. So we're really trying, it may be useful, but it's really beyond the complexity that we're wanting to take on right now. People who are, there is data actually now in bipolar disorder and mania with ketamine, but we're not really doing ketamine with acutely manic people because we really are trying to keep the level of drama down to a manageable amount until we get more experience and can figure out how to do this. So,
Do you know of any other countries in the world that are using this type of treatment? Do you
oh
have
yeah, I
awareness?
mean, ketamine has actually not, it's not really that new, even in psychiatric practice, but it's been pretty under the radar for a long time. It's only recently that it's gotten a lot more press. Australia, England, I mean, there's a lot of other writing that's been done about it.
My last question is, it's incredible that you created something like this, that integrative, way of system to heal the patient, right? do you work with insurance, and how does that, because I have a friend who, or a couple of friends who are doctors, and they deal with this insurance nightmare all the time.
Right.
How do you work with them?
Our practice has always been what they call out-of-network.
Okay,
We're
right.
not, we don't have a membership fee, but we basically charge for our services like plumbers and electricians. But we can help people who have out-of-network benefits from a PPO insurance to collect what they can from their insurance afterwards. So that's been the only way we can be innovative and spend time with people and do things that, because otherwise we'd be struggling to figure out how to get it paid for, and that would actually take up all of my time and 2 of me just to figure out. So we've been unwilling to wait for the insurance system to catch up, so we're doing this out of network. But we do our best to make it what I would call the minimum viable product, like the least amount of attention and time and cost that is going to be responsible. So we're doing our best, but I would just like to acknowledge that this is unfortunately not ready for
Mainstream.
mass consumption, because it takes hours and hours and hours and hours of high functioning, top of their game professionals to pull this off safely right now.
And you mentioned you need a doctor. What kind of, you need a family doctor or a specific, in a specific field?
Probably the best match would be a family medicine doctor or an internal medicine doctor,
Okay.
or maybe some other specialist who wanted to, because we do a lot of complex just general medicine in addition to the behavioral stuff. So, it's just someone who wants to learn,
Thank
I
you.
guess is the best thing. Thanks. Yeah.
Hi. Have you, or has it been used to treat fibromyalgia?
Fibromyalgia. I don't know, actually. That's a good question. I don't think there are any studies on ketamine for fibromyalgia. There's most of the studies from the pain literature are on something called complex regional pain syndrome, which is like if you have an injury and you have pain, and then later the injury goes away, but you still have this brain response to that limb, and it's more of a central brain phenomenon of having pain. These longer infusions of ketamine seem to be very helpful for some people. I actually haven't found literature directly in fibromyalgia, but I think the applicability is potentially really broad. We're just starting with what is currently documented, mostly just because we don't want to, it's complex enough already. We're trying to keep it as simple as we can.
Absolutely. I thought of it when you mentioned the chronic pain.
Oh yeah, I mean, it's an obvious target of curiosity for me, but I
One
don't
thing at
have
a
it.
time.
We haven't tried that yet. So
Thank you.
thanks. Yep, you're welcome.
This NMDA antagonist space is really interesting to me, and I was wondering if you have either any experience or knowledge with the research that's going on with dextromethorphan.
Yeah,
or for that matter,
another
any
another
other
classical
antagonist, but that one I'm
dissociative
really-
drug that has some, recreational use,
Well, I know,
mostly mostly in
Mount Sinai's
preteens.
doing some
Yeah,
trials.
yeah. Dextromethorphan is a subject of some research. I have not looked into it. For some reason, in all of my research into psychoactive drugs over the years, dextromethorphan has never really piqued my interest. So I don't have any direct experience with that.
Thank you very much.
So, yeah,
Great
sorry.
talk.
So I
Thanks.
have a microphone, which means I get last question.
Okay, thank you.
And I want to know what are the next steps for your clinic? What are you hoping to get into next? How's it going to develop?
We're hoping to hire another MD, or maybe 2 more MDs, because it turns out when you start really focusing on helping people and listening to them and working with them over time, there's a virtually limitless demand for that. So we're growing. We'd like to start really documenting how we do things, because we've come up with ways of working with people that are pretty useful and I think teachable. So I'd like to actually, once we have more clinical help, start documenting what we're doing and teaching others how we do it, because I think it's a pretty useful model. And I think also maybe documenting the fact that our patients consume dramatically fewer healthcare resources than other similar patients in other settings, because even though there's a big investment of time up front, we get people on track and then they don't need us much. over time when we're able to make that initial investment. And that's a different perspective from the rest of the healthcare world. So mostly it's just refining our team and then figuring out how can we teach this model of practice. So
Well,
Yeah.
again, thank you so much.
thank you.
It was a wonderful
Yeah.
presentation.
Okay.
And now go to the airport and get a plane.
Okay. Yeah. Thanks.
And